endoscopic carpal tunnel release using the single portal technique. The site for the incision is marked out, centered over the palmaris longus, taking care not to extend radial to the FCR tendon in order to protect the palmar cutaneous branch of the median nerve. Once the skin incision has been made, the retinaculum is carefully exposed. A flap is made out of this retinaculum by releasing the ulnar border. A tenotomy scissors is placed between the retinaculum and the nerve, and a 15 blade is used to release the ulnar margin to create a L-shaped flap. This has a distal and radial base in order to protect the palmar cutaneous branch of the median nerve. The synovium is reflected from the undersurface of this retinacular flap, and then a synovial elevator, a small spoon-shaped device, is used to release the synovium from the undersurface of the transverse carpal tunnel ligament along its entire course. Dilators are passed along the ulnar margin of the nerve to help to create a pathway for the endoscopic device. The device is assembled and then placed into the incision, taking care to apply upward or palmar pressure to keep the blade tip very close to the transverse carpal ligament. This helps prevent the median nerve from becoming transposed between the ligament and the blade tip. The device is warmed with warm saline to prevent fogging. This has been the most effective method to prevent the fogging. The distal margin is visualized and a portion of the ligament can be released. Palpation helps to confirm the distal margin as shown here in this two-frame image. Here you can see the opening or spreading of the transverse carpal ligament that's been partially released. The distal segment is now released under the visualization from the endoscopic device. The complete distal release has now been confirmed, and now the proximal portion of the transverse carpal ligament can be released. Care is taken to retract the skin margins as the device is brought out proximally so it does not create a T-shaped laceration of the skin incision. Complete release is demonstrated with visualized both radial and ulnar flaps of the released transverse carpal ligament. The median nerve can be visualized as well. The retinaculum proximally is released under direct vision with tenotomy scissors. An injection is performed with marking. Care is taken not to perform a median nerve block so that postoperative testing can be performed. The skin incision is closed with a running subcuticular suture, which is easier to remove for the patient than interrupted sutures. A dressing is applied.